So pulmonary pharmacology, let's get started with the antihistamines. Well, you have first generation and second generation antihistamines. Your first generation antihistamines include diphenhydramine, chloramphenemine, hydroxine, and dofrenamine. The mechanism by which these work is they are H1 receptor antagonists. H1 receptor antagonists. And basically what that means is that it prevents the action of histamine, thus reducing the itching, the rhinorrhea, the sneezing, etc. Some adverse effects is because first generation antihistamines are lipophilic, they can easily cross the blood-brain barrier and therefore they cause significant sedation. So it also has mild anticholinergic effects to it. So some second generation antihistamines include loratadine, phenoxyphenidine, and ceftriaxone. The mechanism of action is the same as the first generations. However, because these agents are lipophobic, they do not have the sedating effects and are such a better for a daytime formulation type pill. Now, the adverse effects to the second generation antihistamines are most commonly they have a mild anticholinergic effect such as dry eyes or dry mouth. Now, the clinical uses for these are symptomatic relief for allergies, long-term treatment of allergic rhinitis, usually a second generation in combination with the intranasal glucocorticoid there. It's a nighttime sleeping aid. You use a first day generation, remember, because it is lipophilic. It likes to cause significant sedation, so it has some mild anticholinergic effects in the first generations. So moving right along, let's go to the beta agonists. Alright, these bind at the beta 2 over the beta 1 receptor. So these bind over the beta 2 over the beta 1 receptor. Now the mechanism is it binds to the beta 2 receptor and activates the GS protein, GS coupled receptor protein. Excuse me. That leads to a signaling cascade which increases cyclic AMP levels. Increases cyclic AMP levels in the bronchial smooth muscle cells, which leads to bronchodilation. So you have some short-acting agonists, which are metoprolol, albuterol, and terbutaline. They are used for acute attacks of bronchospasm. And then you have the long-acting agonists, which are usually about 12 hours, and that is salmeterol. That's used in prophylaxis only and generally combined with an inhaled glucocorticoid. Now you have the non-specific beta agonists, such as isoproterenol, which acts by binding to both beta 1 and beta 2 receptors. Beta 1 effects is a significant tachycardia, which limits its use as an agent. Now, the toxicity is aerosol forms usually have low toxicity. So you see skeletal muscle tremors that are common and adrenergic effects. At higher doses, the beta 1 effects include tachycardia and also hypokalemia. Hypokalemia can arise as a result of a transcellular shift of potassium, since we were talking about the beta cells. So that includes the beta agonists. So let's talk about cough therapy and decongestants. Now, cough therapy and decongestants or symptomatic therapy is the mainstay of treatment for the common cold. There are various over-the-counter prescription strength products that can provide symptomatic relief. So we have cough suppressants. This is the common cold generally causes cough by either nasal obstruction or postnasal drip. Common suppressants are generally do not consider helpful are generally not considered helpful for treating cough associated with the common cold. Now, dextromethorphan, which 1 out of 7 people do not have the liver enzyme to break it down. So those guys that decide to robo-trip and happen to be 1 out of those 7, ooh, that's a bad day in the neighborhood for those fellas. So, happens to have dextromethorphan and codeine, which are two commonly prescribed cough suppressants, although codeine has not been found to have an advantage over placebo. Codeine binds to opiate receptors in the CNS, causing an inhibition of ascending pain pathways. It causes cough suppression by direct central action in the medulla and produces generalized CNS depression. Now, dextromethorphan decreases the sensitivity of cough receptors as well as the depressed and medullary cough center, similar to codeine. So, cough expectorants. What do we know about cough expectorants? Well, there's one in particular called guanfacine. Guanfacine. Now, guanfacine is thought to act by increasing respiratory fluid secretions. Increasing respiratory fluid secretions and thereby decreasing the mucus viscosity. So see how guanfacine works? It's a cough expectorant. It decreases the mucus viscosity by increasing respiratory fluid secretion. So what about a nasal decongestant? Well, you have 2 of them. You have, again, pseudoephedrine and phenylephrine. Pseudoephedrine and phenylephrine are your 2 nasal decongestants. And they are 2 commonly used decongestants, although because of its use in the production of amphetamines, pseudoephedrine has been moved to behind the counter. Now, pseudoephedrine is an alpha-1 agonist. Alpha-1 agonist. In the respiratory mucosa, that leads to vasoconstriction. Vasoconstriction, which leads to a decongestive effect. So that's how that works. Also, non-specifically, it stimulates beta receptors, causing bronchial relaxation, so increasing heart rate and contractility. Now, phenylephrine is a potent alpha-1 agonist as well, that causes vasoconstriction, so you also get a decongestion. Now, unlike pseudoephedrine, it does not have any beta adrenergic activity. So pseudoephedrine does have some beta adrenergic activity, whereas phenylephrine does not. So you might not think that at first. So pseudoephedrine has they both do the same thing, but pseudoephedrine also has some beta adrenergic activity in such that it is increasing heart rate, causing bronchial muscle smooth relaxation, contractility, the heart's increased, etc. So oral nasal decongestions provide marginal relief of congestive symptoms. Now, topical, this is important, so pay attention to this. Topical nasal decongestions should not be used regularly, as they can cause significant rebound rhinitis. Rebound rhinitis. So topical nasal decongestion should not be used regularly, as it can cause significant rebound rhinitis. So moving right on to Cromolyn sodium and Nedocromil. So these are some fun ones here. So how do these babies work? Well, the mechanism by which they work is they cause a decreased granulation of pulmonary mast cells. Now this leads to a decreased release of inflammatory mediators such as, you tell me, how about leukotrienes, how about histamine, etc. So that leads to a decreased bronchoconstriction or a decreased bronchodilation. A decreased bronchoconstriction. If I could learn how to spell, that would be great. So you get a decreased bronchoconstriction. So the clinical use, you're going to use this in the prophylaxis for bronchial hyperactivity, especially allergic induced. Now the toxicity, the Cromolyn and the Nedocromil are not absorbed systemically, so the toxicity is low between both of these guys. So that's pretty much all you need to know about those. So let's move on to inhaled corticosteroids. Now, inhaled aerosol corticosteroids are used for maintenance treatment of asthma, and are also used for COPD management. Commonly used inhaled glucocorticoids include betamethasone, fluocinolone, fluisolide is what I meant to say, busonamide, and fluticasone. Now, intranasal intracorticoids, intranasal glucocorticoids are the first line treatment for allergic rhinitis. Let's write that in there. Intranasal glucocorticoids are the first line treatment of allergic rhinitis. So that'll be a test question somewhere along the way. Now, the mechanism by which this works is it inhibits phospholipase A. Therefore, you decrease the synthesis of arachidonic acid. You decrease the synthesis of arachidonic acid and its inflammatory metabolites such as prostaglandins and leukotrienes. Now, prostaglandins and leukotrienes are particularly important in the pathogenesis of bronchospasm. They also act to stimulate the synthesis of the beta-2 receptors in the airway. So the clinical use is it can be used for acute attacks. Can be used for acute attacks, but because of the latency time are generally more used for prophylaxis. Now, the toxicity is similar to other steroids, however, because inhaled glucocorticoids are delivered locally, there are less systemic side effects. So you can get a local immunosuppression like oral candidiasis, or with prolonged use you could cause cushingoid changes, etc. So the list could go on, but that is inhaled corticosteroids in a nutshell for you. So let's talk about leukotriene antagonists. Leukotriene antagonists. Now, leukotriene antagonists act as both bronchodilators and anti-inflammatory agents. That's pretty important, and I would remember that. So the first ones we have are Zarlucast and Montelukast. These are the LTD4 leukotriene receptor antagonists. They have a slow onset and are usually used prophylactically for bronchospasm due to exercise, antigen exposure, and aspirin. Now, Xylulton inhibits the LOX or the 5-lipooxygenase pathway, resulting in a decreased production of all leukotrienes. Decreased production of all leukotrienes by Xylulton. So it's similar uses as the Zarlucast and the Montelukast, or the LTD4 antagonist, but it has a faster onset of 1 to 3 hours. So that's why we like Xylulton sometimes. So Xylulton is more for acute attacks, and Montelukast and Zarlucast are more for prophylaxis, is the way I would think about it. All right. Omalizumab. It's a recombinant humanized IgG and against an IgE. Okay, its mechanism of action is it blocks the ability of IgE to bind to the Fc receptor on mast cells and basophils. Blocks the ability of IgE to bind to the Fc receptor on mast cells and basophils. Omalizumab. Alright. So, therefore, you get a decreased IgE activation of basophils and mast cells. Therefore, you get a decreased release of inflammatory mediators leading to a type 1 hypersensitivity. Now, over time, Omalizumab leads to decreased levels of circulating what? IgE. Now, the use, it's approved for treatment of allergic asthma in patients who are refractory corticosteroids. Because of the mechanism of this drug, it is only useful in patients who are proven to have IgE-mediated sensitivity. So that's Omalizumab for you. Last thing we're going to talk about is Theophylline. Now, Theophylline has two major functions. It causes bronchodilation by inhibiting phosphodiesterase to increase cyclic AMP. So, like I said, it causes bronchodilation by inhibiting phosphodiesterase to increase cyclic AMP, which, number one, increases lipolysis. Number two, increases glycogenolysis. Number three, it increases gluconeogenesis. Number four, it increases epinephrine release from the adrenal medulla, and it blocks adenosine receptors, which leads to bronchodilation. Adenosine is a potent bronchoconstrictor. So if you block the adenosine receptor, you're going to have a massive bronchodilation. So the clinical uses in this, it can be used as prophylaxis. As prophylaxis for nocturnal asthma. Nocturnal asthma, and as adjunctive therapy for patients who have poorly controlled asthma and or other medications that are common. The toxicity, because of the low therapeutic index, Theophylline is quite toxic. Common side effects include GI distress and insomnia. Higher doses can cause vomiting and seizures, as well as cardiovascular effects, including tachycardias and arrhythmias. This drug must be dosed especially carefully when used with cytochrome P450 inhibitors, such as, name two of them for me. How about erythromycin or cimetidine? Either one of those. So you got to be very especially careful when putting people on Theophylline that are already on CYP450 inhibitors. So that covers your pulmonary pharmacology for you in a nutshell. So there you go. Good luck.